Now I'd like to introduce Dr. Bacon, and he is going to be here to talk about the great psychotherapy debate. A little bit about Dr. Bacon. He's a licensed clinical psychologist, and he's in private practice. Has a long history, as I understand, an interest in how worldview structures an individual's reality and how that interacts with the therapeutic relationship and the possibility of positive change and growth. Please welcome Dr. Bacon.
It's a pleasure to be here today. Thank you for coming. Today we're going to be speaking about the changes that are going on in the basic psychotherapy paradigm. And it's kind of a stealth situation because some very big things are happening and it hasn't been well publicized. So while some of you may know about this debate and the interesting implications that have come out of it, to many of you this will be some new information. And because the information is rather radical, I'm going to have different pauses in here because it'll seem like, really? Is that actually true? Does the research really say that? Okay, so the fundamental debate that we're talking about in the great psychotherapy debate is between the extant ruling medical model and a new model that is sometimes called the common factors model, but more accurately called the contextual model. The medical model we're all familiar with begins with an assessment, leads to a diagnosis. Treatment is tailored to fit the diagnosis. Ideally, it's evidence-based treatments, and then we get a good outcome. That's a diagnostic and treatment-centric model and works very well in medicine. The contextual model, people say that it doesn't work so well in psychotherapy. If you take a look at some of the basic claims of the contextual model, you'll see that things right off the bat get pretty controversial. As you're going to see in a moment as I take you through their research analysis and their arguments, they are really coming up with different ideas about how psychotherapy works. Instead of being technique-centric, it's therapist-centric and relationship-centric. It says that techniques lack inherent power. I'll define what that means in a moment, and are actually rituals. That therapists fail to improve from experience. That therapists fail to improve from training, supervision, or continuing education. And finally, that the field has not made any progress, measurable progress in the last 40 years. All pretty radical ideas, and ideas that kind of stand our regular beliefs on their head. So I'm going to take you through their arguments. If you want to look at the source material, these two books here, The Heart and Soul of Change and The Great Psychotherapy Debate, are probably the most outstanding representations of the contextual model. Now today we're starting with the contextual model, but we're actually going to go significantly beyond it. But you have to understand what their model says and the critique to understand the extensions of it. So these two books are really worth reading and do summarize in detail the arguments I'm about to make. So the arguments begin with the training effects. And we all, of course, assume that our training makes us more effective psychotherapists. Unfortunately, the research doesn't actually support that. I have some summaries of some review articles that I'm about to go through, but let me point you toward two studies that are probably the most important ones. The first study was one done by Stroop and Hadley in the 70s. Pretty famous, many of you probably are aware of it. It took college professors and compared them doing therapy with licensed and experienced therapists. And the people they were doing therapy with were what might be called normal neurotics, anxiety, depression, and so forth. The results of the study were that both groups were effective with the clients and then neither group was better than the other. Now that was done in the 70s, and it was a shocking study because, of course, it implies that untrained people can get equivalent results to trained people. But it was a study with a small number of subjects, and so the field kind of moved on past it. Interestingly, it was replicated about 2 years ago. The replication wasn't with college professors. What they did is they took fourth year and fifth year clinical psychology graduate students and compared them to graduate students in history, biology, non-clinical fields. And when they ran the replication with, again, normal neurotics, the history students did just as well as the clinical psych students. So Stroop and Hadley has been replicated. That's the only replication, to my knowledge. It was just done 2 years ago. So it's kind of alarming to those of us in our field. We want to think that we have a body of knowledge. Anyway, when you take a look at some of the quotes I have up here, Malouf is doing a review of all the training programs. His quote is, there's really no evidence that the coursework, the research, and the training ends up showing an improvement in clinical outcomes later on. And just another review article. This one is from Hill and Knox, and you can probably see it up on the screen. Again, you can see that when you review the training programs carefully and look at the outcome variable of, are trained people better at outcomes than untrained people, you find that training has virtually no effect. So Stroop and Hadley has been replicated, and it's been substantiated by these review studies. While this is not inaccessible material, we don't really act like our psychotherapy training is ineffective and does not help us get better outcomes. So I'm just going to move on from this one, but this is the no effect from training. The second one has to do with experience, and this one is perhaps even harder for us to accept. It's very easy to test this because we have lots and lots of studies where you have multiple therapists and we're measuring their outcomes. So we can find out how many years of experience the therapists have and see if the more experienced therapists get better outcomes. So you can do meta-analysis on this very easily. And as you can see, there is no evidence that experience results in better outcomes. Now, that does not feel true to me as a therapist. I suspect it does not feel true to most of you. But the research is really crystal clear about this. So the first part, you really have to see how easy it is to measure this one and how many studies. We're talking about thousands of clients, hundreds and hundreds of therapists. You can read these two quick summaries. There's actually a finding right now that is even a little bit more alarming. It's not as robust as this finding that experience doesn't make us better. This finding says that people get better within 2 months to 8 months of beginning practice. They hit their highest level of effectiveness and then gradually get worse over the next 20 years. It's been compared to a balloon gradually letting its air out. Now, I didn't list that one because it's not quite as robust and not quite as well substantiated, and it's not really important for the work that we're doing here today. But anyway, this no experience effect does not feel true at all, but it is really a robust finding in the literature. That leads us to the third area, the so-called Dodo bird theory. Most of you have been exposed to this. It's the idea that all the schools of therapy work, but none are better than the other. They all get equivalent positive results. And it's called the Dodo bird theory because of the Alice in Wonderland quote, "Everyone is one and all must have prizes." Dodo bird theory is robust replicated in lots and lots of studies. Probably most of you have heard about the dodo bird theory. The dodo bird theory is a really big problem for what's called specific factors. Most of you are aware that when you talk about the effectiveness of psychotherapy, we talk about the effectiveness that is due to specific factors. That means the techniques that we're using and the school of thought that we are adhering to. So if I'm psychodynamic and use psychodynamic techniques, those are specific factors. Then there are common factors that go across all schools, usually defined as a therapeutic alliance with a wise and caring individual. So we have specific factors and common factors. If dodo bird is true, it's the death knell for the specific factors theory. And a little logic explains why that's so. Remember, we have all these schools. We have humanistic existential, we have systems, psychodynamic, and so forth. They get a positive effect size that we can measure. If all of them get the exact same positive effect size, even though they're doing radically different things. In systems theory, we're looking at the individual embedded in a system. In psychodynamic, we're looking at the unconscious and inside the person. CBT, something really radically different. How likely is it that these radically different ideas get exactly the same positive effect size? So illogical. The way you come to dodo bird, of course, is you do a lot of meta-analyses and you throw out the bad studies, keep the good studies, and when you do the meta-analyses, the different schools of therapy are equivalent. That's how the dodo bird was discovered, and that's how its proponents look at it. But on the other side, the people pushing for specific factors say, well, I get what you're saying, but look at all these studies that show that one approach is better than another. And then the dodo bird people say, well, that's mostly due to bad experimental design and allegiance factors. Allegiance means if you believe in the therapy you're doing, you get a better outcome. So if I'm CBT and I'm doing both CBT and psychodynamic, but I love CBT, I'm likely to get a better outcome doing CBT than psychodynamic. That's allegiance factors. So the dodo bird people say that. The specific people say, I don't care what you say as long as we have some studies that show it's better. I don't buy your allegiance. And so there's a stalemate because the specific factor people are very aware that if dodo bird is true, all the claims that techniques have inherent power just go completely out the window. And all we're left with is common factors. You know, relationship, therapeutic alliance with wise and caring person. Now, you've heard there's a common number that's thrown around. Sometimes it's 11, sometimes 15%. So when you read about this in graduate school or in any article, the articles will say something like, dodo bird is true and supports that common factors are really important, but about 11% of the variance in change is due to specific factors. When you read that, it sounds like specific factors and common factors are both being endorsed. And that's what most of the field thinks. But what that actually is representative of is all those studies that show something is better than another one that the dodo bird people say should be thrown out or averaged in. So there isn't a strong finding. That's just part of the controversy over is dodo bird real or is specific factors real. Now, those folks doing those research articles have been unable to settle whether dodo bird is true or whether specific factors are true. That's why you keep hearing common factors are really important, but 11% is due to specific. However, the contextual model people have very cleverly looked at another way to decide if dodo bird is true. And that's what I'm going to take you through now. And this doesn't talk about allegiance or meta-analysis or any of the rest of it. The first thing is the no failure finding. Some people think there's 250 psychotherapy systems. Others say 400. I thought 400 was a fun number, so I put it in as 400. But basically, the finding is whether it's 250 systems or 400, nobody has ever invented a psychotherapy system that doesn't work. Every one that's measured works. Now that's kind of interesting, because in other fields, you can come up with ideas that fail. I mean, if I'm an engineer, I can come up with a bad way to build a bridge, and it will fall down. There's good ways and bad ways. Not in psychotherapy. In psychotherapy, if somebody has a passionate moment and invents a system, and you measure that system, it's going to work at the same rate as all the other systems. That's the no failure finding. The second thing is the difficulty we've had in developing a placebo psychotherapy thing. All of us understand that the best way to do research and find active ingredients is double-blind studies. They require a placebo treatment. So every time any researcher has tried to develop a placebo psychotherapy, something that looks like psychotherapy but has no clinical effect. If you have something that has no clinical effect, all the clients immediately say, this isn't therapy. And the moment you improve it to where they can't tell the difference between that and the treatment condition, it works as well as the treatment condition. So that's called the problem with developing a placebo. Those two are related, obviously, the no failure and the difficulty with placebo. So that obviously suggests that everything credible works. Kind of common sense, right? But now we want to look at specific factors and go back to our training effect. Remember, the research says there's no effect from training. What do you learn when you're getting trained? Well, a bunch of stuff, but two of the major things you learn is the systems. You get trained in psychodynamic or CBT or whatever you're getting trained in, and techniques. So people that are trained know systems and techniques versus the untrained. If the systems and techniques have any inherent power, if they're responsible for some of the variance and improvement in clients, then trained people would best untrained people. This is a really important point, so I'm going to say it slightly differently. Everybody who's trained knows techniques versus the other people. They ought to have a training effect if techniques have any power. If techniques are rituals, and I'm going to get into what rituals are in a second, but ritual would be anything you believe in that is credible, that if you go through it and you and the therapist agree, it'll make you better. That's a ritual explanation of how you get better in psychotherapy. But training, you teach people techniques with inherent power. So the no training effect suggests there's no inherent power in techniques, that they're actually rituals. Then you go straight to the experience effect. More experienced people know more techniques, and they've practiced them more. So in that sense, they're going to be better, and their techniques, as they're utilizing them, they'll be more and they'll be doing them better. So we ought to have an experience effect if our techniques have inherent power. So when you put together those three arguments, no failure, no training effect, and no experience effect, you resolve the dodo bird argument. There are no specific factors in psychotherapy that affect outcome. There are only common factors in psychotherapy: rituals, expectations, and relationship. Now, this is quite the morsel to digest, because it literally means that if you go off to do continuing education and you get trained in EMDR, or you get trained in a new cognitive technique, you're not going to be a better therapist. It means if you learn a new system, you're not going to be a better therapist. I just came back from the APA in Chicago last month, and I assure you that 80% of all the workshops being offered there assume that if you learn a new technique, you're going to be a better therapist, or a new system, or client characteristics. So this is really hard to accept, but the research is crystal. The third point, put simply, we're placebologists. I can't hardly even pronounce that word, but if it's believable, it works. Interventions can be seen as placebo delivery devices. Now, I want to explain the concept of privileged knowledge because it's going to come up in the rest of our discussion. Privileged knowledge is that knowledge that's owned by a profession, in this case, the psychotherapy field. Our privileged knowledge is everything we know about psychotherapy. Privileged knowledge in auto mechanics would be like how to rebuild an engine or, do a brake job or something. Privileged knowledge in engineering is how to build bridges or highways or whatever. So every profession has privileged knowledge. The assumption is that if you develop your privileged knowledge, the field is evolving and getting better. Remember back on that first slide when they said no improvement over 40 years? What they've done is they've looked at effect sizes. Those people, the contextual model people, looked at the effect sizes they were getting 40 years ago versus what's going on now. We're getting the exact same positive effect we got back there. None of our evolution of privileged knowledge, none of the studies we do, none of the new systems we've developed, none of the new techniques in the last 40 years, like DBT, EMDR, ACT, all of those, has done anything to improve. So I'm going to just give you a concrete example and then stop and take questions because this is about 1/3 of the way through. So imagine that we have two cultures, and both cultures have the same mental health model. They believe that spirit possession explains mental health symptoms. So in the first culture, there are real malevolent spirits that actually come and possess people. And those people get symptoms, anxiety, depression, whatever, psychotic experiences. And then they go to exorcists. The exorcists in this culture have found that certain exorcisms actually work and throw out the spirits, and other ones fail. So they actually have some interventions that fail. These are real spirits, so they can only be thrown out by actual real exorcisms. That's our first culture, okay? Now in culture 2, who also believe that spirit possession explains mental health problems. But in this case, the spirits are constructs. They're made up. There are no real spirits. In that culture, people just believe they're malevolent spirits that possess people. They get the exact same symptoms that they get in culture 1. Depression, anxiety, psychosis, whatever. The level of suffering from the imaginary spirits is equivalent to the level of suffering from the real spirits. And they also go to exorcists. In this culture, however, the exorcists are effective like they are in the first culture, but everything they do works. There are no bad ways to exorcise the spirit. They go through the exorcism. The client feels the spirit leaving, and when they feel the spirit is gone, their symptoms are in remission. The exorcists believe the spirits are real. The clients or patients believe the spirits are real, and there is a benefit from the exorcism. But there are no failed exorcisms. Everything works. So, obviously, the medical model where we started fits culture one. There's real spirits, real pathology. You have to diagnose what kind of spirit it is. If you get the right kind of spirit, you can apply the right kind of exorcism. And if you do that, the exorcism has innate power. Because you're trained in it, you are an expert, and you actually throw the spirit out and people get better. That's what the medical model says psychotherapy is like. In culture two, with the made-up spirits, everything works because if you believe it, of course it can throw out an imaginary spirit. In that particular culture, the pathology is also a construct. In other words, the spirits are made up. So of course, anything that's done can be effective at throwing out the spirits. The people feel a lot better when it's over, and nobody bothers to question whether the spirits were real and whether the exorcisms had innate power. So that's a kind of a concrete way to think about the findings of the contextual model versus the medical model. So I've given you a lot of material really quickly. I'm going to pause for a moment. And anybody who has any questions about what we've discussed. Yes?
Just fit it in where it goes, because I'm a little lost. I made a career on preparing untrained intervention, a whole slew of folks that didn't have training but did the human one-to-one. If I'm repairing because of experience and training that doesn't exist, how come there's damage?
You're repairing because of experience and training. How comes there's damage?
I collected a career of working with folks that had gone to non-trained individuals.
Oh, untrained people cause damage.
Right.
Right. And trained people cause damage.
Correct.
So
if there's no training and there's no reason for experience, how was I able to make a living?
How did the exorcist make a living in culture two? In other words, look, this research says that untrained people can help folks change. Untrained people can do damage as well as help folk change. We're all very aware that the fact that many or most of us in this room are licensed in some way to do psychotherapy doesn't automatically mean we won't do some damage. We hope we'll do well, that's our intention. But of course some of us do damage. And all of us have had other therapists, people who've seen other therapists, and we've seen them afterwards and we say, what the heck was that therapist doing? That didn't help. But we've also seen people that are life coaches do damage. And we've seen people that are spiritual healers do damage, and so forth and so on. So addressing the fact that previous practitioners didn't do well by some of the clients you saw later would be as true for the licensed therapists as the untrained therapists. That's what the research says. Yes?
For me, the crux of the matter in hearing all that you've shared is that belief is the primary criteria for success in anything you think or do or therapy or whatever.
Right.
And I believe that.
Yes.
The only thing that gets me through life is belief.
Yes, that is 100% of what this actually suggests. We're going to look at the implications of what this means for training and practice in the next section. That's where we're going in a moment. But yeah, that is exactly what comes out of this, is that relationship plus belief and expectations, in other words, common factors, are what's driving psychotherapeutic success. Now, what to do about that, how that's different than the medical model, and what doors open and close, that's, again, where we're about to head. Yeah?
Does the contextual model imply that mental issues aren't real?
Well, remember, suffering is real. So if you define mental health issues as suffering, nobody could ever say that they aren't real. But look, let me give you a perfectly good example. A couple's in a relationship, and somebody comes and says, I saw your boyfriend cheating with this other woman. And she believes it's true, so she's furious and in despair. And then it turns out it was the person's identical twin that was with the other person, and all of a sudden the woman's cured. Was her suffering real? Yes. Was the basis of her suffering, her assumptions, real? No. So the contextual model and where we're about to go doesn't in any way suggest that suffering isn't real. So if we define mental illness as suffering, and remember something that's, I'm sure, obvious to all of us here, but allow me to say it out loud. The research here on psychotherapy, our field in psychotherapy overlaps with organic damage. If you get somebody that's had a head injury and develops an organic personality where they're very angry all the time, which is certainly possible, comes in and says, my husband is angry all the time, he needs anger management training. It's the same anger, but we divide it into, this is coming from the material world. They had a head injury, they have brain damage, and the anger seems to be coming from that, versus from the psychological world. And those two things have different levels of reality. We're all used to working in that. There's such a big debate in our field. How much is it neuroscience? How much is it so forth and so on? It's a really interesting discussion. Today's talk is not about that, but we should understand that there's a lot of overlap between what I called culture one, which would be sort of the brain injury explanation for anger, and culture two, which would have a more psychological explanation. Yes?
Sorry if I missed this, but the research you were speaking to in the beginning, that was research supporting the contextual model. Is there research that supports the medical model?
Yes. When I was talking about the debate over the Dodo bird theory, and I said that if you accept Dodo bird, specific factors go out the window. So everybody who's arguing against Dodo bird is trying to support the medical model. And to do that, they point toward all the studies that say one technique is better than another technique. And so, for example, you'll hear people say, CBT is better for anxiety. And look at all these studies that prove it's better for anxiety. Or they'll say, DBT is better for working with borderlines. And they'll try to prove that DBT is better for borderlines. So there's tons of people that have been trying to prove the medical model. What's alarming is that they have failed so profoundly. None of us, unless you'd already been familiar with this, how many people already knew there were no positive effects from training or experience? How many people knew that before I said 1, 2, 3? And all the rest of us are where the field is. Of course we believe. I feel my training made me a better therapist. I'd be really surprised if you guys didn't feel that way. I definitely feel my experience makes me better. I'd be surprised if you guys didn't feel that way. The fact that it doesn't on average do that is what's so darn shocking about this research. Yeah?
So when we're talking about training, we're talking about specific training on therapies or approaches to cure like something.
Sure.
Rather than, like for instance, I'm trained as a social worker, and the
Yes.
training that I got is not a training that, oh, we're gonna do CBT and that's what is gonna cure people. You get the baseline that support those core values like the alliance, the relationship, and things like that.
Right.
So I guess, I don't know if when you talk about training, if you're referring about being specifically trained on a specific technique, or if you're talking about training about education in general.
Yeah. What we're talking about here is generic psychotherapy divided into schools of psychotherapy. Now, if I get training, for example, on the laws of California about 5150-ing somebody. I'm going to be better at that than somebody who's untrained in that, because that training is more like culture one. There's something actually to learn, and when I know it, I'm more effective at 5150. But the research here is about general psychotherapeutic change, feeling better, being less depressed, less anxious, more stable, personality disorders getting better, all of that clump. So in many of our trainings, we have certain specific parts that are actually not related to this generic psychotherapy. The contextual model does not stop where I went. They actually go ahead and do some things about practice, which we're not going to have time to talk about today. So I don't want you to think that contextual model doesn't have a lot of really interesting things to say about what to do with this information. They do, and I recommend those 2 books and series of related articles. But where they do stop is they do not bother to ask, why do we not get better with experience? And why does training not do it? And why do techniques, how come we can't develop techniques? And how many thousands of books have been written and hundreds of thousands of research articles are privileged knowledge? How come that doesn't make us better? So that's where we're going to go in a slightly different angle, because we're going to ask, this thing that feels so wrong to us, how come? And again, fortunately, we have a pretty common sense answer to that. We're going to start with what's called a cross-profession analysis. Remember I mentioned Stroop and Hadley, college professors versus licensed experienced therapists. They got the same outcome. Now suppose we'd done the same study, but the college professors this time were competing against cardiologists, and the task was to install a pacemaker. Would there be equivalency? We would say that's crazy. It would be 100 cardiologists, 0 professors, right? It's the exact same if you compared in a lot of professions. I can't rebuild an auto engine. I can't design a bridge. I can't do a soils analysis to figure out if the foundation is going to be solid on a certain. There are lots of professions that have really clear training effects, that have really good privileged knowledge, that if I'm not trained in it, I am not competent in that profession. And we all know those kinds of fields. They're all very common sense. We also know there's other fields like psychotherapy where training is not necessary. Education, sales, leadership. Now, in those fields, they have training and they think they're better from experience, but lots of us who went to high school know that the experienced teachers were not necessarily better than those brand fresh teachers who were excited about teaching. And we also know that professors at universities, our highest level teachers, are required to have how much training in education? 0. How about leadership? Has anybody ever been promoted to be head of a department without any training? And some of them are great at management, and even the trained ones often fail at management. So we get a clump of professions where you don't have to be trained and you can be pretty darn good, and another clump where if you aren't trained, you're going to be clueless, hopeless, and absolutely inadequate. Think about the difference between those professions. Engineering, auto mechanics, metallurgy, and so forth, versus leadership and sales. The professions that operate in psychological reality, in what might be called constructed reality, versus the ones that operate in material or scientific reality. You can see that there's a pretty clear division between fields that have an easy time developing privileged knowledge and getting good training effects versus the ones that really have trouble. That suggests that the reason that we're getting these findings in psychotherapy is because psychotherapy operates in constructed reality, not in material reality. When we say it's all in your head, common unscientific statement, we're talking about it's all constructed. And that's true with leadership, and that's true with a variety of other fields. And it is not true in the STEM fields. So that is one argument about why psychotherapy has no training effects. Because if you're in a world with no training effects, basically anything that you do that's believable and credible works. Because in constructed reality, you make it up as you're going along. And whatever people agree with you about, that's the truth in constructed reality. If we all believe at Cottage Hospital that consensus leadership is the only way to go, and that we should beat down all hierarchies and not have any expertise, but everybody has a voice, and the janitorial staff has as much to say as, there are a bunch of leadership models exactly like this, then that becomes our leadership model. If we believe in a table of organization, then that becomes a leadership model. Now, that's one reason that we say that we're getting these no training and no experience, because if you're in constructed reality, I'm going to explain that in a little bit, but think about why I brought up culture 1 and culture 2. Culture 2 with made-up spirits and made-up exorcisms, it's all made up. That's constructed reality. In culture 1 with real spirits and real exorcisms that have innate power, that's material reality. Now, Constructionism is really a complicated topic, again, not on our agenda today. There's a lot that can be said about Constructionism. We're not going to go down that road because it would take too much time. But I think you can see the difference between constructed and the material world, and how professions operating in constructed reality are going to be operating by different rules. There's another theory that explains this, and this is the anthropological theory. Okay, so we're a Western culture. We have a Western theory about mental health and mental illness. We're aware that other cultures at other historical periods had different theories. Evil eye, spirit possession, too much or too little mana, witchcraft. We're very aware through basic anthropology that every culture has its own theory of mental illness and mental health. Everybody believes that, including the people in favor of specific factors and scientific psychology. But when Western culture came along and started looking at mental health and did it from an anthropological perspective, they said, well, look, all these cultures believe different things. They're clearly making it up. There's no witchcraft. There's no spirit possession. Mana is a constructed idea. There's no too much or too little mana. That's all just made up stuff. Poor culture, they're superstitious. But our culture, we're going to use science to go after mental health. So we're going to be the apex culture that actually deals with mental health. We're not going to be superstitious. Our ideas are not going to be constructed. Our ideas are going to be founded on observation and the scientific method. Even the specific factors people agreed all the other cultures were constructed and made up their models of mental health. Now, the idea that we're scientific means that we're doing independent observations of real things, that when two people look at the same phenomena, they're going to measure it and get the same result. Basic principles of scientific theory, right? All of you who have worked in the field of psychotherapy are very aware that if I look at a client, I'm going to get something very different out of that client than if you look at a client. I know, for example, that we're all supposed to get all the notes and consult with all the previous therapists because they scientifically have treated our client before we got them, and we're going to build on their scientific work. And I also know that many therapists never bother to get the notes of the previous therapist. Why? Because they're very aware that that therapist had a view of that client that is probably very different than your view of that client. It doesn't mean we aren't told to do it in graduate school, and it doesn't mean that a lot of people don't do it. But when you're practicing in the field, it's not like that. You're very aware that the preceding person had a very different view because everything is fluid. We're not even sure we have the same definition of the self. You know, there's an Enlightenment definition of the self, but those of you who are keen on postmodernism may know that postmodern people do not believe the self even exists inside the person. They argue that the self is an ephemeral construction that exists in the dialogue between me and the person I'm interacting with, and that I have multiple selves that change. They don't even believe their ideas of the self are the same. But here's the basic idea. The contextual model, when they did the research, destroyed the idea that we have a scientific psychology. When we can't develop a technique, when we can't develop any privileged knowledge, even though we've written these hundreds of thousands of, it's clear that our Western psychology is as constructed as all the other cultures before. Because if ours was truly scientific and was not superstitious like everything else, we would have training and experience effects. We would have discovered techniques with inherent. That's where the contextual model mixed in with anthropology blows away and says Western psychology is as constructed as anything else. And those of you that are keen on cross-cultural psychology, which I suspect a number of people are really interested in that here, and what do you always hear from cross-cultural psychologists? They always say, what you think is true in your part of the culture isn't true in my part of the culture. What you think is a neurotic condition or even a psychotic condition, in my part of the culture, we don't see it that way. And I'm sure you guys I've been to a bunch of those lectures. Those cross-cultural psychologists are really convincing. I mean, it's pretty much sort of cultural imperialism to discount their findings. It's just really inappropriate. So the anthropological analysis says our culture is just as constructed as every other culture. That we're really operating in culture too. That our ideas of psychopathology, some of you probably followed the debate about the new DSM and whether grief should be considered a mental health problem. It was a pretty provocative discussion, right? Because every time you develop new diagnoses, you're pathologizing another human condition. That was the basic argument. And there were people on both sides. No, this really is mental illness. No, it's just regular human response. Remember, in part of DSM, there are organic conditions that are not part of constructed reality. We're just stipulating that. I'm giving you the broad strokes. So when I say all of the diagnoses, it's within the context of that stipulation. So basically, what we want to realize is that psychotherapy is practiced in constructed reality, not in material reality. And the person who made the point that everything is belief, in constructed reality, if you believe it's true, it's true. The woman who thought her boyfriend had cheated on her, it was real for her at that moment, even though it turned out to be the identical twin. Thinking about things that way are really different. Now I'm going to go to the common factors idea. What a lot of people say at this point in the talk is, are you saying it's all about the relationship? Well, I understand that because I've always thought it's all about the relationship. How many psychotherapists do you hear say that? And say it credibly and with, you know, they believe it and they practice it. I am saying that. That's why the contextual model school used to be called the common factor school. But when the contextual model or this lecture says it's all about the relationship, we're actually talking about a very different relationship with different components than people usually mean when they say a therapeutic alliance with a wise and caring person. That's what we're going to do. So, I have 3 sayings here that will help you redefine what all about the relationship means. The first is the famous, "In the land of the blind, the one-eyed man is king." Now suppose you're in culture 2, and you're an exorcist, and all the other exorcists believe they're real spirits. And you happen to know, maybe because you went to a lecture like this, that there aren't any real spirits. And you also happen to know all the other exorcists think that their techniques are changing people. You're aware that the belief is changing people. Okay? How much of an edge does that give you over the people who don't know that? Now, when we talk about a wise therapist, what we're normally talking about is a person who has lived life, had experiences, understands how the culture works, can anticipate what people are going to feel, can work through why somebody feels like something. Perhaps they've worked through their own neuroses in some way. That is a really good definition of wisdom, and I'm sure we all aspire to being ever more wise as we grow in life. That's all wisdom inside the culture. That's wisdom within the prevailing view of the culture. If you are the only exorcist that knows there are no spirits, you have a wisdom that nobody else in that culture has. And how is that wisdom going to give you an edge? That's wisdom about the constructed nature of the culture. Well, one of the things it's going to do right off the bat is you're not going to be scared of spirit possession. You're also not going to be terrified when your client starts talking about spirit possession and all the weird symptoms. You're also going to feel that everything is a lot more malleable than you used to think. When you believe there are real spirits that only respond to techniques with inherent power, you're living in a very constrained world. When you start realizing it's a totally fluid world, that there's no real spirits. So when I say there's no real psychopathology, remember the differentiation? I didn't say there was no suffering. I said that the definition of this person's sick because they're borderline, this person has clinical depression, so they're going to have to be on antidepressants the rest of their life. Those definitions of psychopathology are totally constructed. When you know that that's totally constructed, you have an edge over people who believe in that stuff, because to them, psychopathology is reified. It's set in concrete. It's really stable. It's hard to move. There'll be resistance if I try to move it. When you recognize that the suffering is real, but the reason for their suffering is made up, you're like the person who knows the woman's boyfriend has an identical twin. Now, we all wish it was easy as that. But in fact, you do know that it wasn't her boyfriend that was messing around with that other girl. Knowing that makes you optimistic. It infuses you with a sense of confidence. And it gives you a different type of wisdom than the person who has wisdom inside the culture. It doesn't mean we should stop developing our wisdom inside the culture, but this is a whole nother angle on it, and your clients can feel it. Why is that important? Well, as the person said a few minutes ago, if it's all about belief, are you going to get a better outcome as a client if you find your therapist charismatic and believable versus shaky and immature. Obviously, if it's all belief, the nature of the therapist becomes a lot more important. The second one, a saying we all know, when all you have is a hammer, everything is a nail. If you are technique-centric, if I've been trained in CBT or psychodynamic, or even if I'm eclectic and I put together a couple schools, when I see a client, we are all supposed to see a client with sort of the eyes of a child, like the unformed, or what's the Taoist term? The unmarked object? No, there's a Taoist term for it. Anyway, it'll come to me. We're all supposed to see each client as sui generis, as absolutely unique in themselves, and we're supposed to feel them without any preconceptions. But the moment I have techniques that I believe in, I'm actually saying, is this person going to work better with exposure therapy or with a different CBT technique? Because my technique-centric nature makes me see clients through the eyes of that. So when I believe in techniques, I will make sure that I see the client through my belief in techniques. The ability to fit the intervention to the client is the second big thing that comes out of this constructionist analysis. We already did the thing about the wisdom. If I am open to seeing the client as they are, and I fit them better, then aren't their beliefs going to be enhanced? If I speak their language. Every school of therapy that's credible teaches us client-centeredness, speak the client's language, assess the client as they are, don't lay your preconceptions on them, watch out for countertransference. It's not like this is a new idea. Why is it new? Because the moment you abandon the belief that techniques have inherent power, you don't see everything as a nail anymore. You can't really see a client as they are when you believe techniques have inherent power. That's the second one. The third is a quote from a guy named Scott Miller. He's probably it's arguable, they have a bunch of big dogs in the contextual model. He's probably the main person. His quote is, "It's not what the therapist knows, but who the therapist is." When we are in the medical model, we are trained to be people that can apply techniques in a caring and competent manner. When you're doing research on techniques, you want the therapist simply to be competent, but not to be special in any way. The moment that you get rid of the concept that techniques have inherent power, what are you going to do to be a better therapist? Well, have greater wisdom through constructionism, see the client as they are, and do whatever you can to develop yourself. We develop therapists by teaching them systems and techniques. We give them supervision. And while some of our supervisors are really excellent, mature people, wise people, and they'll help us work with countertransference and things like that, it's also true that we default toward techniques have inherent power. Because we only had 3 hands up in here that said that they already knew that there were no training effects and no experience effects. And that means the vast majority of you probably thought if you went to a workshop, you'd be a better therapist.
What does it say about our need to have CEUs?
We are going to have to be asking a lot of questions like that. We have 10 minutes left, so I want to throw it open to some more questions here. Yes?
I guess, in reality, going deeper, I don't think we can really, or even if we follow the social constructed theory, we always are going to have a biased lens. We cannot see the patient as clearly from what is their experience, because it's their experience and the only one who know, their life. So I think, but I guess being aware of that is, I guess.
We all try to approximate it as best we can. And the more we, remember, when you're trying to become a better therapist and get better outcomes, you're not trying to be perfect. You're trying to move from average into being a superior therapist. You're trying to, you hopefully are going to say, instead of helping 60% of the people come to me, I'd like to be able to help 75. So each one of these things is, proportionate. If we get better at seeing clients the way they are, if we get a sense that reality is more fluid than we thought, then we can bump up from 60% effective maybe to 75. That's what we're shooting for. Yeah.
In light of what you were talking about with the organic brain injury leading to anger, what about treatment with things like psychedelics, neurofeedback, things that may actually alter the neurochemistry, the underlying terrain of the patient?
Well, here, let me get rid of this thing. I already stipulated that there's a blend between material and constructed. Psychedelics are fundamentally a really profound ritual. The people that have done the best work on psychedelics, I was just at AP, I mentioned earlier, there, for one reason or another, there was lots and lots of workshops on psychedelic-assisted psychotherapy. It's kind of really coming up now. We're all aware of ketamine. It's being practiced in our own community, but it's coming even more and more. But fundamentally, you can't simply take LSD or magic mushrooms or ayahuasca or any of these things, because otherwise all of our teenagers who partied with them would all be healed. And most of the teenagers that party too much with that stuff seem more mixed up, not less mixed up. So there aren't very many people I know that would say that ayahuasca or mushrooms are going to be healing in themselves. What they do is, if they're introduced correctly, you're going to have an altered state experience. And then if that experience is interpreted as, let's say you have one of those profound things where you feel like not afraid of anything, really connected to the universe, one of those classic profound experiences. And this therapist that you trust, after you're coming down and you're debriefing it, says, people like you who've had this experience have often had profound shifts in their life because they've felt this and they've gone on to manifest these beliefs as they go through the regular world. And if you really trust that person, and by the way, that is true, that statement I made is true, and the person believes it, then the fact that they went through that will change them. A teenager went through that and just partied on, man, and didn't get changed at all is really important to understand.
I was Mithofer, and Mithofer published a pretty well-known study now on PTSD patients out of University of South Carolina. Now you're in third phase stuff with MDMA. But in those studies, they were taking people who were totally resistant to any medication, who were homicidal and suicidal, and they had at least, and that was a blinded placebo-controlled study. They had 100% improvement, and after like a 90-day period, they had like a 60% that no longer qualified for the diagnosis at all. So there may be something actually going on here physiologically. Now that was a very controlled dosage. That was not just party on guard.
No, I understand. Those are the kind of workshops that I went to in APA. Remember, there is a blend. That's what we're stipulating, a blend between the material. But be aware that if you get a group of people that are resistant to change and you blow their mind with the psychedelic experience, you're going to get some changes. And then you're going to frame the changes as meaning something. Is that likely to be positive for that person who's stuck? If you frame it right and it's done in a safe environment and it's set up correctly so there's a positive expectation. But the idea that simply, I am really dismayed when people say, oh, my doctor said I have to have 6 ketamine experiences and my depression will be better. Not because that might not work, because it does work for some people, but because the doctor might not have been saying, and I'm going to prepare you for it, and we're going to debrief each one, and we're going to tie it into all the other changes from psychedelic experiences, and we're going to work really carefully with this symbolism of what you experienced in your altered state, because instead of getting 30% of the people better, maybe you get 80% better. Yes?
Could you say a bit more, please, about who the therapist is, or therapist charisma?
Sure. So when you're sitting there imagining that you're in constructed reality, the first task of any culture is to train people to see reality the same way. I should rephrase that. The first task is probably attachment theory. Allow me to call it the second task. After you've gone through basic attachment theory things, the second task is all of us in the West have to learn to see the culture the same, right? So we get trained to see reality the same way inside a culture. So who trains us? Well, every encounter with every cultural member teaches us how to see reality. But we all know that there are some cultural members, key individuals, who have a bigger say in how we see reality. Parents, teachers, mentors, famous people, whatever. The moment you think that the way you see reality is fluid, you can get a definition of what charisma is. Charisma is the ability of us to see a person as having the ability to define reality for us. So if reality is fluid, which is not what it feels like to us most of the time, but we know in constructed reality is fluid, we could just as well be Native Americans in 1500 on the Great Plains as we could be sitting here today. And we'd see reality totally differently. Reality is fluid. People raised in different cultures live in different realities. And those realities are set by everybody in the culture, but specially set by key people. If we ascribe the power to let somebody define our reality, that can be called charisma. So we should aspire to be charismatic. Now, I've given a big talk about how we have to see clients as they are, that the client belief is supreme, that this whole approach is more client-centered than standard therapy, but it's also more therapist-centered. Because to the degree that we realize there's no power in techniques, the power comes from fitting the client and from us putting our energy behind it, our explanation. If I say to this person in an altered state from the previous thing, people who have that experience can integrate it into their life and be different, that's going on my credibility. And if I don't have techniques, I better do stuff to develop my own credibility in a different way. And so the aspiration to be charismatic or to be seen as charismatic by our clients is not the first thing that you get taught in graduate school. Yes, we're told we should be able to be persuasive, be good listeners, have a rationale for what we're offering. But the idea that we should actually cultivate charisma sounds much more like being a shaman or something than being a psychotherapist. But when you're in constructed reality, the cultivation of charisma is one of the 3 major things. Seeing the world as constructed, discernment, that edge, meeting clients as they are, and understanding that our own credibility actually defined the therapeutic alliance with a wise and caring person. It's still the same common factor. It's the therapeutic alliance with a wise and caring person. But wise and caring start ending up being defined differently and being developed differently. It's really a different world, even though it's all about the relationship.
Thank you. You can hold questions, and I'm sure Dr. Bacon, if he has time to.
Yeah, happy to talk to folks after. Yeah, you're welcome.
Okay.